Hi, my name is Nicole Manley, and I am here for my case study. I looked at a patient. He was a 46-year-old African American with a serious mental illness. According to the patient, he was originally diagnosed with bipolar in 1998 and was then placed on Social Security disability and has not worked since. The patient reports at the time at the time of the interview, he was feeling hopeless, helpless, and depressed. He states that he has had a manic episode before and described it as having a bunch of positive thoughts and attempting to accomplish a lot of things in a short period of time. He had a lot of energy. He was feeling on top of the world. He says that after a while, though, he started to sit back and he started to watch people, and his thoughts stopped making sense. And he also noticed that he would find himself seeing people or seeing things that weren't there, and also hearing his family talk to him, and they weren't there either. Patient states that he's always paranoid and he always feels like he's on the alert. And he also states that while he was taking medication, those symptoms did go away. But he's been off his medication for 2 months, and he reports that his symptoms are slowly starting to return. He has PTSD from childhood abuse, and the patient discussed some of his childhood with me. He was telling me of a time when he was 12 years old, and he found his mother in the kitchen where his stepfather, was abusing his mother, and she actually shot him. He remembers taking the gun from his mother, and when the police arrived, he tried to tell the police that he actually shot his stepdad instead of his mother. He also was discussing another incident where he had seen one of his friends' children taken away by a man who was a family friend as well, and later found that little girl in a ditch, stabbed to death. And so, as a witness, he had been placed on the stand to testify, and the man is now on death row. So he has some feelings of guilt and resentment also regarding that situation. During the interview and during the appointment, the patient was very tearful. He would go into a full-out cry. He was able to gather his thoughts back up, and then he would, essentially cry some more. The patient states that for the most part, he does have nightmares over different aspects of his life, mainly childhood situations. He states that he doesn't have any difficulty falling asleep, but there is times when he wakes up and he's unable to get back to sleep after having a nightmare. As far as childhood, he says that he was a good student. He was on the baseball team and the football team, and was team leaders, team captains for both. He also states that once he joined the military, he was a leader in the military, and he ended up becoming ill during basic training and missed a lot of basic training. Once he was better, a lot of the men that he had come in with had already gone to different duty stations, and a lot of them had deployed to Iraq, and he was not able to go. So he felt guilt behind that, and also some of them did not come back from Iraq. So he still is troubled with the fact that he feels like he should have went to war and that he should be dead instead of his quote-unquote battle buddies. The patient was homeless for several years because he tried to escape a lot of the problems he had. He felt like if nobody knew his address or he didn't have an address, he wouldn't be able to be located. The man that was on the death row, every time he went back to court to have his case relooked at, the patient would have to return to court also and relive all of the events and memories. Has a very vivid memory of all the events that occurred. He was homeless for several years. He moved on to Texas, Houston, Texas, where he also was homeless. He doesn't really indicate why he moved to Houston, other than the fact that he lived there for several years and then recently relocated to Las Vegas. Since he was put on Social Security disability, he's been surviving, and he says that he survives enough off of Social Security and that he's not really looking for any additional VA compensation. However, the VA does want him evaluated. He is currently residing in VA American Homes, which is a service provided to veterans that are homeless in Las Vegas. In looking at his risk factors, or the risk factors for schizophrenia, we looked at his, or the main ones I looked at were a family history of schizophrenia, exposure to viruses, toxins, or malnutrition while in the womb, increased immune system activation, having an older aged father, taking psychopharmacological medication during adolescence and early childhood. And in discussing with the patient, his symptoms appeared early, but he does not recall any family history of schizophrenia or any other mental illness or substance abuse. He also does not recall having his mother having any problems while she was pregnant. However, he can't say that she didn't either. As far as with his father, he doesn't have any history on his father. He didn't know his father and is unsure of the age of his father. And he doesn't recall being treated with any medications as an adolescent. Early adulthood, he was treated with Zyprexa, Haldol, Paxil, Prozac, Zoloft, and Ativan as early as 1998. But at that time, he was actually being treated for the symptoms that he's presenting with today. The patient, let's see here. As far as the diagnosis of the schizophrenia, he needed to have at least one symptom. Of the first three, which would be delusions, hallucinations, or disorganized speech. The patient presented with some auditory hallucinations and some complaints of visual hallucinations. He also did present with some negative symptoms such as flat affect, isolative behavior. He also states that these symptoms have been going on for quite a while. He also reported the symptoms for depression and being hopeless and helpless. Let's see. He also reports having a lot of anxiety with his daily activities, unable to leave the house without increased anxiety, unable to identify where the anxiety comes from, feelings of irritability, and also unable to concentrate, unable to focus. The severity of the symptoms at this point, the patient is, he presents neat and clean in appearance. He's appropriately dressed. He's wearing the blue jeans, red collared shirt. His hair is shaved bald and his facial hair is neatly groomed. He's tearful and anxious. His speech is clear with a normal rate and tone. However, when he cries, it becomes crackled. It becomes hard to understand. You're able to redirect him, and he will clear his voice and regain his composure. His mood is anxious and depressed. His affect is congruent. Concentration at this time is fair, and his memory is actually very good. He's able to recall vivid descriptions of his past, including colors of clothing, smells that he encountered. His judgment and insight are fair. The patient knows he needs help. However, he's reluctant to follow up, and also he'll retreat to the streets when he feels like he's overwhelmed. At this point, he has help. He has a friend that is encouraging him to seek help. He also denies any auditory or visual hallucinations at this moment, and also denies any suicide ideations. He says he hears the voices intermittently, but at this point he hears nothing, and he does understand that they are not real. Patient's alert and oriented, ×4. In looking at the research to guide the practice recommendations and treatment recommendations, I looked at a study by Newman, Turnbull, Berman, Rodriguez, and SERPER. It was an investigation on the symptoms of schizophrenia and the contributing factors of violent victimization and traumatic non-interpersonal experiences. They attempted to determine if patients diagnosed with schizophrenia and who also met criteria for PTSD would develop more mood and anxiety symptoms than those without PTSD. And essentially, referring the patient for PTSD and treating PTSD with SSRI as a first-line recommendation was put into my treatment plan. Their studies showed that emotional distress exhibited by the patients who are identified as having PTSD and schizophrenia were more intense than those without PTSD. And they conclude that essentially in the study there were 70 participants, and none of them were diagnosed previously to PTSD in their charts prior to the evaluation. They're stating that PTSD is a very treatable condition, and not treating the PTSD will cause more severe symptoms of schizophrenia. Therefore, we need to better recognize the symptoms of PTSD so that treatment can be, we can essentially treat those patients for the PTSD, which will help with the symptoms of the schizophrenia, including the increased anxiety and the exacerbation of the auditory and visual hallucinations. The second part of my, the second article that I reviewed was a study of the importance of identifying the patients with PTSD as well as the first-line treatment, which it suggests that after the studies that SSRIs are the suggested first-line treatment. It emphasizes that medication should be taken for 12 weeks in order to evaluate the effectiveness, a minimum of 12 weeks before we're able to evaluate it. And I chose sertraline as my my starting medication. I would start that at a dose of 50 milligrams daily and titrate up as patient tolerates. I also would refer the patient for psychotherapy for PTSD and have the patient follow up with a VA as he has benefits there. Also, just the patient does have a history and is currently symptomatic with hypertension. He doesn't have very good education regarding the medication and the signs and symptoms of hypertension. He's complaining of headache and dizziness at times. His blood pressure was elevated on this visit. So I'm definitely going to refer him to contact his primary care provider immediately following the visit, just so that he can avoid any complications. He was educated at the end of the visit on all the medications that he would be starting. He was going to also be put back on Zyprexa 10 milligrams at night for sleep. I'm sorry, for psychosis, and that the doctor also recommended trazodone 100 milligrams at night for sleep, just to help hopefully improve his sleep. After speaking with after reviewing some more research, I looked and investigated more on prazosin for the nightmares. That wasn't prescribed in my study, but that is definitely something else I would look at going further treating this patient. Other than that, I have nothing else follows. Thank you.